EMDR for depression, the evidence, the retraction, and what guidelines actually say. So picture this. A 2016 paper reported an 85% drop in depression symptoms. That is an implausibly large effect. The math did not add up, the author could not produce the raw data, and the paper was retracted in December 2025. The journal's new publisher delayed the retraction notice for 14 months. Retraction Watch called it too good to be true in June 2026. The paper had been cited 41 times, including in another meta-analysis published in the same journal. Before we get to what the evidence shows, here is what EMDR actually is. Eye movement desensitization and reprocessing was developed by Francine Shapiro for post-traumatic stress disorder. Standard EMDR is a manualized 8-phase protocol with bilateral stimulation while the patient holds a target memory in mind. The VA-DoD and APA guidelines both list it as a recommended trauma-focused psychotherapy for PTSD, so the well-established indication is trauma. Depression is the off-label extension. So what does the depression evidence base actually look like? 3 independent meta-analyses, Carletto 2021, Dominguez 2021, and Seok and Kim 2024. The exact effect sizes, sample counts, and COI disclosures are on screen. All 3 are positive, but the bar for evidence-based treatment is much higher than this. The studies are small. The conflict of interest footprint is uneven. And there are essentially no head-to-head randomized trials of EMDR versus C.B.T. for depression. 3 positive meta-analyses is a starting point, not a verdict. Here is the part that does not get quoted enough. The conflict of interest fingerprint is uneven across the EMDR for depression evidence base. The exact COI disclosures for each study are on screen. None of that invalidates the findings. But when the most cited reviews in a literature are partly authored by their own included study investigators, the effect sizes should be read with one more degree of caution. The certainty is lower than the headline numbers suggest. The retraction in more detail. Matt Williams of Massey University flagged the paper on PubPeer because the quality of life index averages were reported to the 100th decimal place when the underlying scores were restricted to whole numbers mathematically impossible. The journal's editors investigated and decided to retract. The retraction notice was published in December 2025, a roughly 14-month delay. AAAS Science Partner Journals became the journal's publisher in early 2025 and did not prepare the retraction notice until late August. The teaching point is not EMDR is fake. The teaching point is what to look for when a single-arm before and after study reports an implausibly large effect. So what do the guidelines actually say? NICE-NG 222, WHO-MH-GAPIG V20, and VA-DoD M.D.D CPG all recognize EMDR for PTSD. The exact guideline names, treatment lists, and review dates are on screen. None of them list EMDR as a recommended treatment for primary major depression. This is not a gap in the guidelines. The guidelines are responding to the actual evidence. 3 positive meta-analyses with overlapping authorship, conflict of interest disclosures, and no head-to-head randomized comparisons against first-line treatments is preliminary, not guideline grade. The guidelines are doing exactly what they should be doing, waiting for stronger evidence before recommending a treatment for major depression. And the misconception that EMDR is broadly effective for depression is not coming from clinical practice. It is coming from the public conversation, where EMDR works for trauma gets heard as EMDR works for depression. That distinction matters, and it is not the fault of clinicians who follow the guidelines. So where does this leave us clinically? The bottom line is on screen. For PTSD, EMDR is guideline supported and should stay in the toolkit. For primary major depressive disorder, EMDR is not ready for routine clinical use. The first-line treatments for M.D.D remain C.B.T, IPT, behavioral activation, pharmacotherapy, and combinations. We need substantially more independent, unbiased randomized trial data, particularly head-to-head trials against C.B.T and against medication, before EMDR for depression can be considered alongside those first-line options. The Hofmann DeprEnd protocol is an interesting research application, but it is not ready for routine clinical use either, for the same reasons. EMDR is a good tool for trauma. On the current evidence, it is not a tool for major depression. For questions or episode ideas, drop them below and subscribe for more psychopharmacology breakdowns. Educational purposes only, not a substitute for clinical judgment.